Happy EMS Week from the KCEMS offices. We hope on behalf of the entire KCEMS team and executive board that everyone has felt appreciated. We greatly appreciate everything that you do. Today I'm here with my friend, colleague, and toxicologist, Dr. Brian Judge, and we're going to be talking about cyanide toxicity. This is a topic that I know many of you are passionate about and that we all could learn more. Brian, you're obviously very busy as a toxicologist and emergency physician. Can you tell us a little bit more about your training and what exactly you do as a toxicologist?
Sure, Todd. I'm a medical toxicologist. I did a 2-year fellowship after my emergency medicine residency. I trained at Indiana University and then came back to Grand Rapids and set up or helped establish a clinical toxicology service. And so it's really evaluating and treating poison patients at the bedside, which would include also evaluation of smoke inhalation victims who've been exposed to carbon monoxide and potentially cyanide as well.
We know that cyanide toxicity is not common. Can you tell us a little bit more about the frequency of cyanide toxicity and the chemical nature, what happens with cyanide toxicity?
Absolutely. It's fortunate that cyanide toxicity is not very frequent because it is one of the most potent toxins known to man. A very small amount can kill very quickly. It is a carbon molecule that it's triple bonded to a nitrogen molecule that really wreaks havoc at the cellular level and kills almost instantaneously depending on how that person is exposed to cyanide. I've probably encountered less than half a dozen potentially cyanide poisoned patients in my 20-year career as a medical toxicologist. And if there is a significant exposure to cyanide, usually in the form of a fire, where carbon material and nitrogen materials are burned, it will generate cyanide gas, and it can render a patient unconscious and kill them within a matter of minutes.
I know that you mentioned that you've treated approximately 20 patients in your career as a toxicologist. I know that you've shared some data on the national prevalence of cyanide toxicity. Could you share a little bit more of that information?
Oh, absolutely. Probably less than a half dozen patients actually for cyanide poisoning. Because if there is, again, I want to stress that if there's a significant exposure to cyanide, it's going to kill that person almost instantly, and they won't be salvageable. But in terms of national data related to cyanide poisoning or toxicity, there's about a case a day that is reported to our national poison data system. So over the last 10 years, there's been about 3,500 potential cyanide poison victims reported to this database.
Obviously, the treatment of cyanide toxicity has changed in my time as an emergency physician. Could you take us through kind of our previous treatments for cyanide toxicity and what you're using currently as a toxicologist?
Sure. There's a couple different treatments for cyanide poisoning. The old treatment was the Lilly cyanide kit, which is no longer manufactured. And the way that the Lilly cyanide kit worked was to administer a nitrate, so amyl nitrate and sodium nitrate. You would give amyl nitrate through inhalation, and then sodium nitrate through IV, and then that would create what's called methemoglobin. And the methemoglobin has an iron molecule in it in a state that it avidly attracts cyanide, and then it forms an inactive compound that's then excreted in the urine. We also would give sodium thiosulfate as well as a sulfur donor to an enzyme known as rhodonase, which is very prevalent in the liver and muscle tissue that helps detoxify cyanide. There's a very minor pathway of cyanide detoxification through a vitamin B12 precursor known as hydroxycobalamin. And that has been used for, almost 40 years now over in Europe. And then it started gaining wider spread acceptance and use in the United States as a modality to treat cyanide poisoning or potential cyanide poisoning. The side effects are not as great, particularly in terms of affecting oxygen carrying capacity in somebody who might have developed carbon monoxide poisoning concomitantly with their cyanide poisoning.
If I called you with a patient who I thought had significant cyanide toxicity, what treatment would you tell me to perform for that patient?
I would recommend, if it's available, Cyanokit, which is hydroxycobalamin. 5 grams is the standard adult dose. It's given intravenously. In somebody that the actual dose is 70 milligrams per kilogram, up to 5 grams, and you can repeat that dose. You can also give sodium thiosulfate as well as a sulfur donor to help detoxify cyanide. And there's some other options available too if they're available, and one of those is hyperbaric oxygen therapy. But these patients that have cyanide toxicity can, if they survive to the hospital, can still and if had a significant exposure, can undergo seizures, coma, and cardiovascular collapse pretty quickly.
Many of our providers wonder about the timing of treatment for cyanide toxicity. Obviously, we have issues of getting the medication to the patient versus bringing the patient to the hospital where we can treat their cyanide toxicity. Can you tell us a little bit about how important the timeliness of treating for cyanide toxicity is?
Well, if you strongly suspect a victim has cyanide poisoning, then early treatment is, of course, the best therapy. The problem is that there's no standardized guidelines for the use of the Cyanokit, and the initial signs and symptoms of cyanide poisoning can be signs and symptoms of other disease processes, and so patients may have anxiety, confusion, headache, chest pain, shortness of breath before they go on to develop seizures, coma, and cardiovascular collapse. And so I think it's real hard to, knowing what the cost of the Cyanokit is, a lot of patients may complain of either some chest pain or shortness of breath, and you can't obviously give the Cyanokit to every patient that you encounter on scene. I think unless you strongly suspect that there is cyanide involved, in particular in the setting of a fire, because that's probably where you're going to most likely encounter it, unless that person has available to them some kind of cyanide tablet or a reagent where they use cyanide.
So, Brian, for our pre-hospital providers, what might a common scenario for patient complaints, what might a cyanide toxic patient look like in the pre-hospital environment?
Well, initially, it typically occurs in the setting of a smoke inhalation victim where carbon monoxide can be a problem, or is typically more of a problem than the cyanide is. And it really depends on what type of materials are involved in that fire. With today's world, there's a lot of plastics that can generate cyanide, a lot of materials that contain nitrogen and obviously carbon, and that generates cyanide as well. But the cyanide victim really initially can have nonspecific complaints that we see in a lot of our other patients that are encountered in the pre-hospital setting. So they may complain of headache, dizziness, abdominal discomfort, anxiety, some chest tightness. As that cyanide has more of an impact at the cellular level, that then leads to seizures or convulsions and cardiovascular collapse and coma, and then ultimately death in a short amount of time.
Brian, when we see patients in the hospital after smoke inhalation or exposure to a fire, help us understand the role of cyanide toxicity, like testing in the blood. When should that be done, and how do you interpret those results?
In my experience, cyanide testing is really not useful because it takes a while to get that test back. The hospital may not have that test readily available, and you need to treat that patient before you have any test results back. And so we'll use as an example your smoke inhalation victim. If they are still alive and they are hypotensive, they have low blood pressure, they're not mentating well, they're intubated, and that is somebody that I would probably administer the Cyanokit to in the emergency department. I've done that in the past. And then you can always get a cyanide level after you've administered the antidote to see if it in fact may have been an issue. But if you strongly suspect cyanide poisoning, you should be giving that antidote prior to ordering any cyanide level. And if your victim is awake, alert, and talking to you, then it's not cyanide poisoning.
Brian, as a toxicologist, we obviously don't carry the cyanokit or the hydroxycobalamin on every single ambulance. We have it available, but providers need to call for that resource when they think it might be needed. What sort of pre-hospital scenario might you envision that would be good for providers to think about potential cyanide toxicity and to start requesting resources to come to the scene for potential treatment of cyanide toxicity?
Sure, I think any fire in which cyanide could be generated and you have victims that could potentially have significant cyanide toxicity who are still alive is a scenario in which I would think requesting the cyanokit would be appropriate. Again, with the vast majority of patients who are exposed to cyanide in a significant way, they're going to probably be dead already, unfortunately. It's those patients who have maybe lost consciousness or hypotensive. If you can get them to the hospital quickly, I would oxygenate them, do your ABCs, and intubate if needed, but get them to the hospital as quickly as possible and get that cyanokit administered in the hospital. Or if you do have the cyanokit available, then you could certainly administer the cyanokit pre-hospital in that situation.
One of the questions that we get from our providers, I think it's an interesting question. I'd love to hear your thoughts on it. Their question related to cyanide exposure, is this a cumulative process versus just a one-time event? And I think that the question relates to some of our firefighters who maybe have been exposed to multiple different fires. Is there evidence that just a single exposure to cyanide versus multiple cyanide exposures could be harmful to our providers? Is that anything you have any expertise on?
Well, so cyanide can cause, there are a couple scenarios in which cyanide can cause problems from accumulation, and it's usually done, it's iatrogenic and it's done in the hospital when a patient's on a nitroprusside drip, because there is cyanide molecules in that medication. And if the patient has renal failure, that cyanide can accumulate and then cause toxicity that way. And usually sodium thiosulfate is given concomitantly with that medication to detoxify the cyanide that is liberated from that medication. In terms of accumulation from repeat fires, I don't think it's probably a significant problem as long as the appropriate precautions are taken. You have to protect yourself at the scene too. I will use an example of chronic cyanide exposure is people who smoke. Smoking generates small amounts of cyanide and also carbon monoxide too, in levels that have been considered potentially toxic by some scientists.
Are there any contraindications to the cyanokit or treatment with hydroxycobalamin?
Really, the only contraindication I know, there's no contraindications that I'm aware of that have been placed on by the manufacturer in the labeling for the product. But if you have an allergy to hydroxycobalamin, would probably be the biggest contraindication, but it would be hard to determine. I don't know many people that have an allergy to vitamin B12, since it's essential for a lot of different functions in our body. It's an antidote that's very well tolerated. You can actually see some of the bigger side effects are red discoloration of the urine. Everybody gets that, 100%. You can also get red or redness or a rash involving the entire body that can last for a couple of weeks, headache, and then also hypertension too.
As you mentioned, with relatively few side effects, some of our providers wonder, why don't we just administer this to anyone who's had smoke inhalation, who's been exposed to a fire? It would seem like maybe that would be a great treatment strategy.
Well, unfortunately, it's very expensive. That's probably the biggest drawback of the medications, close to $1,000 a dose. And so that has really prevented us from making it available on every single pre-hospital rig nationwide. And also, I don't think there have been good guidelines developed for its administration. So you have to choose your patient population very carefully versus just giving it broadly to every single smoke inhalation victim, when in fact, if they're awake and talking and vital signs are good, it's unlikely that they've had a significant cyanide exposure.
Brian, obviously you said that cyanide toxicity is not something very common. Are you aware of any studies or the literature, what it says about use of cyanokits in the pre-hospital environment?
I am. They're smaller studies. I think some of the data is not great out there. They have suggested improved survivability in patients who have gotten the cyanokit versus those who haven't. But again, when you look at the data, it's hard to parse out who in fact had cyanide toxicity and who didn't, and instead it was just given empirically. So I wouldn't really hang my hat tremendously on the current body of literature that's out there in terms of supporting a, I guess, national program for getting cyanokit on every single hospital rig until the cost comes down. Again, it's $1,000 a dose, and you have to use it judiciously.
Brian, do you have any insight into why this antidote is so expensive?
It's like anything else. I don't know. Everything's so expensive today, but I'm not sure I don't know actually if it has orphan status, Todd, or why a vitamin would cost so much. But usually the doses of vitamin B12 that we use in the clinical arena are a fraction of the 5 grams. So I'm sure there's probably production costs, marketing, research, all that. So,
Brian, what would you want a pre-hospital care provider to know about cyanide toxicity and treatment?
Sure. I think, again, cyanide is very deadly. If there's been a significant cyanide exposure, that patient will most likely have already died on scene. If you have somebody that you think has been poisoned with cyanide and is very ill and have available to you the cyanokit, then I would administer that cyanokit, particularly if it's a lengthy transport time. And so somebody that I would consider using it pre-hospital if they have hypotension, cardiovascular collapse, seizures, things of that nature. I would not probably administer the cyanokit to somebody that has some of those nonspecific findings of cyanide poisoning, because those signs and symptoms are seen in so many other patients that are encountered out in the field.
Brian, as a toxicology expert, could you tell us a little bit about the science of cyanide toxicity?
Yeah, cyanide, it's extremely potent, which is, to me, very intriguing because it's simply two molecules hooked together with a triple bond, a carbon molecule and a nitrogen molecule. And it wreaks havoc at the cellular level. It's a cellular poison, and specifically, it's a mitochondrial poison. So it really destroys the powerhouse of the cell and the cell's ability to make energy aerobically, and you really have to resort to anaerobic metabolism. And so once cyanide has its effect on the electron transport chain, cytochrome A3, I think it's the last cytochrome in that electron transport chain, what is happening is you're breaking down ATP, but you're not able to synthesize ATP, so you get a generation of net hydrogen ions, lactic acid, and then also acidosis. And this happens within a fraction of time once cyanide enters the body. And once it starts to inhibit oxidative phosphorylation, that's when things go haywire. That's when the signs and symptoms start. your body is not able to extract oxygen, and so venous blood can actually look very oxygen rich or almost cherry red is what's described. That's very rare though. So people, when you read textbooks about cyanide poisoning, it will say, oh, the patient may have cherry red skin or cherry red retina. That's only seen in less than 10% of victims. So I wouldn't bank on that in terms of helping you discern whether or not somebody's been exposed to cyanide. But that's really what sets up this cataclysmic event in the body. It's just this nasty cellular poison that interferes with aerobic metabolism, your body's ability to make energy, and then the things that ensue afterwards is just terrible, and that's why people die quickly from it.
Brian, we really appreciate you taking the chance to talk to us today, and I'm wondering, from your expertise as a toxicologist, is there anything you'd like our pre-hospital providers to know about toxicology or to be thinking about when they're caring for patients?
Sure. I think the biggest thing is to, regardless of the scenario, and I'm sure I can only envision the scenarios that you guys and gals encounter every day, and I appreciate all that you do to help us as emergency medicine providers and as a medical toxicologist, but make sure you're safe and protect yourself, particularly if you're in a situation where there may be chemicals or drugs of abuse or agents like cyanide. So you need to have that personal protective equipment because cyanide can be inhaled. About 50-60% of the population can detect the bitter almond odor of cyanide. That means the other half can't. So don't rely on that as a screening tool to rule out a potential cyanide exposure. But if you've got a victim who's down in a fire, you need to think of both carbon monoxide and cyanide and make sure you've got the appropriate protective equipment on. Also, if that patient is still alive by the time you transport, they may need to be decontaminated. Don't do mouth-to-mouth. It's kind of a no-brainer these days, but particularly if there was a chemical ingestion of cyanide or chemical form of cyanide that was ingested, because that can be on their lips.
Brian, I'm wondering what is helpful as far as information, or when our pre-hospital providers are handing these patients over to an emergency physician, what type of historical elements, treatment elements are the most relevant from the cyanide toxicity? What information do you want to make sure is communicated?
It's a great question, Todd. I am so dependent on our EMS crew and first providers in providing a story for us on what was going on at the scene with that particular patient, particularly with a smoke inhalation victim or a toxicologic patient, because it can provide so many clues as to what that particular person may have been exposed to and help guide me as a clinician in how I'm going to manage that patient that's now before me in the emergency department. And I can run through multiple scenarios, but telling that story, gathering that information, that's a hard job to do because I'm sure it's chaotic at the scene. But by gathering your wits and collecting all the data and information you can, and then giving that to clinicians at the hospital is so beneficial in helping us do our jobs better. So it really boils down to a clear line of communication.
Brian, tell us about cyanide levels and smokers.
Sure. So I don't think I need to preach to you, Todd, smoking's bad. It liberates, hundreds of chemicals into the bloodstream, including carbon monoxide, various metals, but also cyanide too, and cyanide concentrations that are considered potentially toxic. And I've been consulted on patients who are in the hospital who have potentially toxic cyanide concentrations, and then they're awake and talking to me, their vital signs are fine, there's no acidosis, and lo and behold, I do a little digging and it finds out they're a smoker. So just one more reason to quit if you're a smoker.
I want to thank Dr. Judge for taking the time to come and talk to us today about cyanide toxicity. I also would like to thank all of our providers who submitted questions and who have brought this important topic to the forefront. From my perspective as medical director, we have a protocol for treating cyanide toxicity. I think the bottom line is if we encounter a situation where we think a patient might have cyanide toxicity and we have access to the antidote, we want to call for that resource early. If we have it on scene, we want to administer this resource. But in the other situations, we want to rapidly transport that patient to one of our local emergency departments where they can continue to receive care.